Hi, good afternoon, everybody. Welcome to Meet and Eat Together with Melissa Gerson and my very good friend, Nicole Naggar, who's a psychiatrist and a specialist in the treatment of eating disorders. And she's here today to talk to us a little bit about how the brain works in people who struggle with eating difficulties. And so before we get to that, we're going to engage in our typical structure of our Meet and Eat episodes, where we're going to start with checking in about our food components for the meal. We're going to set an intention for the meal. Then we're going to chat while we're eating. And then at the end, we'll be able to move on and work on skills for moving on from the meal experience. So, Nikki, welcome. Thanks for joining us today.
Yeah, thank you so much for having me. It's a pleasure.
So this is also a good time if any of you have any friends that are struggling or even just interested in learning more about eating disorders. This is a great time to tag a friend or invite a friend to join. We'll be together for about an hour and we'll be going through a typical meal structure together. So this is the structure that we use in a treatment setting to give people support around eating. So invite friends, the more the merrier. So we'll start with the meal components. Now, in the treatment setting, in our setting, we give our patients guidelines around how to put a meal together for themselves. And the guidelines we give for meal support are generally not super specific. So we don't ask people to measure their food or weigh their food or get too worried about the quantity of the food that they're putting on their plate. We really want to try to get better at eyeballing our meals, to be able to look at a meal and know that it's adequate and that it is going to meet your needs. So sometimes we do that by saying, if you're going to bring rice, try to make it about a fist size of rice. That's about a serving of rice. Let's start with that and see how that feels. Or if we're going to advise that somebody bring a piece of fish, it should be about the size of your palm. That would be a typical serving and at sort of the minimum necessary to meet your needs. We'll tend to say things like grab a handful of chips rather than weighing the chips or portioning the chips with more specificity. And this is our way of moving out of that sort of position of being super detail oriented around food and into a place where you can just be more flexible and lighthearted about how you go about your eating. So today I brought a meal that is some leftovers from dinner. I made this myself and I'm not so sure how it's going to taste the day after, but it's a kind of a teriyaki chicken that I made in a pan, and I have some brown rice, and then I have some green beans that are sauteed in oil, and I add a little bit of salt. And this is one of my favorite vegetables. And Nikki, do you want to share your components?
Yeah. Let's see if I'm doing that correctly with the computer. Yep. Can you get it? Oh, that's better. So I have here salmon with a ginger soy glaze, and I have some stir fry vegetables, which I just used the leftover sauce from the cooking the salmon. And then I have some white rice. I love the sticky rice.
That's really good. I'm impressed. Yeah. So what we usually think about is, do we have adequate protein? Do we have adequate starch? Is there a fat source? And so, for example, in my meal, the chicken was cooked in some oil in addition to soy sauce and honey. The vegetables were sauteed in olive oil. Nikki, it looks like you have, there's a sauce on your salmon that probably has some kind of fat component. And also the salmon itself has a fat source in it as well. So it looks like both of us ended up with pretty balanced meals. So after we check in around the meal components, what we do is we set an intention for the meal. And during intention setting, that's where we think about anything in particular we want to have on our minds during the meal. So some of the things that people think about might be using a very specific skill throughout the meal. Maybe they want to tap into some self-compassion or self-validation. Both of those are tools that I'm going to teach at a later date. But for those of you who are familiar with those strategies, those skills, that might be a good thing to think about today. Sometimes people set an intention just to complete their meal because that in and of itself is difficult for them, or they might want to challenge themselves with something a little bit different or outside the norm. Some people think about how they want to focus their energy and their attention on the conversation so they don't get locked into thoughts, any kind of negative thoughts or worry during the meal component. So, and there are many other intentions that are perfectly acceptable and helpful. So you can feel free to think about for yourself what you might be working on, what you want to think about during this meal. And so we're going to begin eating. I'm going to set a timer. We're gonna give ourselves about 30 minutes to eat. That's about a time frame that we think is kind of a reasonable time frame to complete a meal. And it allows you, if you can eat a meal within 30 minutes, it really allows you to be able to have a lunch date or take a break from work and be able to get your meal in. What we notice with people who struggle with eating disorders is that sometimes meals can take a lot longer. The pacing can be a bit slow. Sometimes we also notice that people can be quick eaters, and some folks want to work on that so they can kind of slow down the meal and just let it last a little bit longer. So depending on where you are, you can kind of think about your own pacing, but I'm going to try to set a reasonable pace with my eating, and you can follow along if that's something that you're working on. So in 15 minutes, I'll let you know that we're about halfway through with the meal component, and then I'll give you another heads up when we have 5 minutes left for the meal. And so Nikki, I'm really happy that you're here. We've worked together many times, and we're also friends through our children. And so it's really nice to be able to hear from more of a science perspective what happens in our brains when we struggle with food. And also when we struggle with some of the mood conditions that we often see coincide with eating disorders or eating struggles. So maybe for the start, could you tell us a little bit about, and also just a note that Nikki's probably not going to be able to eat as much during the talking portion. I'll probably do more of the eating, and Nikki's going to answer a lot of questions. And then Nikki, at the end, when I'm teaching a skill, you can get more of your lunch in if that works for you. So can you start by telling us a little bit about how medication is used in the treatment of eating disorders?
Sure. So it's important to just start off with, whenever we're treating a patient, we're going to take into consideration the patient as a whole, because we really have so much of their individual needs that we need to address. So we're going to take a complete and thorough assessment of the patient and their history. And beyond that, there are so many other factors to take into consideration when we are thinking about this important strategy, which is deploying medication as an important tool that could be a part of our arsenal. And we do need to think critically about how we're going to use this and if we're going to use it. So one of the first things we're going to think about is, what eating disorder are we dealing with, right? Because evidence-based medicine practices, they do tell us that different diagnoses have better evidence to support treatment with medicine for those diagnoses than others. So for example, anorexia nervosa and ARFib, avoidant restrictive food intake disorder, there's not as much data to support that medication is going to change the course of those outcomes versus bulimia nervosa and binge eating disorder, right? Another consideration to take into account: what co-occurring psychiatric disorders are involved in this patient. Experts know that there are psychological sequelae as a result of the malnourished state in and of itself, but we also do know that these patients are sometimes also dealing with bona fide comorbid, coexisting psychiatric conditions, whether it be OCD, PTSD, bipolar disorder, panic disorder. Then we could consider a range of personality disorders. All of these things need to be taken into consideration because they influence the presenting symptoms, they influence the prognosis, and they therefore influence our decisions about how treatment is going to unfold, right? Then, of course, we want to take into consideration what co-occurring medical issues could be at play here, and how potentially could that impact our choices with regard to first line treatment, right? And so we want to think about, does this patient have an underlying endocrinological issue, for example? And if so, has this been worked up adequately? Have they, so do we know what we're dealing with? Have they gotten treatment for it? Is this something that could be a confounding variable at play that could be influencing the presentation and therefore our treatment choices, right? Just by way of making this a point, I've recently had quite a number of women with PCOS. And
Can you say what that is, just in case?
yes, of course. Polycystic ovarian syndrome and co-occurring either bulimia nervosa or binge eating disorder. Sometimes the bulimia nervosa turning into a more binge eating disorder type of trajectory. And this kind of makes sense if we think about the underlying pathophysiology involved in PCOS, given the insulin resistance, given the slowed metabolism, and how that can mess with our brain reward circuitry and our sensation-seeking behaviors. There are a lot of, factors that basically go into our decisions.
It's interesting because I think people forget that emotions are brain-based. Anytime we have a feeling, anytime we have any kind of emotional response in our bodies, it's a result of our circuitry, our brain circuitry. And so I think it's interesting to understand. It would be interesting to understand a little bit more about just the neurobiology of eating disorders. What is actually happening in the brain that might be leading to certain emotions, certain behaviors?
Sure.
I know we don't have a ton of study on the human brain in eating disorders, but at this point there's a fair amount. So we have some learning that we can draw from. Can you share a bit with us?
Sure. So I can point to a few studies. One such study completed by a team of psychiatrists out at the University of California in San Diego. They studied the brain reward center involving 3 different groups of women, recovered anorexics, recovered bulimics, and a healthy, normal comparative group who had never, quote unquote, had an eating disorder. And here we were looking at basically the activity in the primary gustatory cortex. And what the study design was such that here these patients were fed from a syringe pump every 20 seconds with a sweet sugar flavored substance while their brains were being scanned. And so, what we found is that we saw critical differences in the way that these patient populations displayed activity in this reward center in the brain. So the recovered anorectics, they basically had less activity in this area of the brain. The recovered bulimics, they showed more activity in this area of the brain. And this is relative to the healthy control group who had never had an eating disorder. And so what the evidence allows us to conclude is that when we have these different atypical responses to presenting stimulus, this can be a predisposing, if you will, condition that can lead to maladaptive ways of relating to just normal behaviors like feeding ourselves.
In other
Right?
words, if eating is more rewarding, there's a higher probability for that person that they may use food to reward. Whereas if there's a lower reward response for another individual, it's less likely they're going to turn to food as a source of soothing or comfort.
That's
And in fact,
absolutely right.
can we also conclude, I think there have been some other studies that show that in particular with anorexia, not only is the brain less likely to light up around reward with food, but other parts of the brain that are more involved in control tend to actually get activated. So in the face of like a tasty sweet drink, it sounds very unappetizing the way they infuse it, but in the face of something that could be experienced as rewarding to take in, that some brains may actually respond with distaste or lack of a positive reward response, or even more discomfort and perhaps more control being activated.
Yeah, and we were talking also earlier about how you could have that concurrent, more fight or flight, arousal, anxious activity, right? And so that actually is a nice segue to look more closely and discuss more closely the restrictive disorders.
Mhm.
We do know that nutritional rehabilitation is going to improve physiological outcomes and psychological outcomes. But what is so important is that we impart to our patients and that they understand that actually the undernourished state itself is inhibiting and causing deleterious effects in and of itself, right? And so in a landmark study in the 1950s done by Keyes and his colleagues, we had actually, where they had studied semi-starvation in a group of like healthy males. So these were people who didn't have any eating disorders, right? We directly saw that the underweight state, the malnourished state, caused these folks to develop a depressed mood, restricted affect, heightened anxiety, poor concentration, perfectionism, obsessionality. So we saw that the way that their neural networking, and their traits, if you will, manifest traits, we saw that these things were changing as a result of the semi-starved state in and of itself.
Yeah.
And I think it's so important for folks to understand. We also saw in these people, despite not having an eating disorder, that they developed increased preoccupation with food, right? And that they developed unusual patterns of eating, playing around with their food, dawdling, not being able to finish, right?
Yeah.
So it better helps us understand the pathophysiology involved in this group of patients. In fact, that these folks, whatever may be there, it's certainly intensified in terms of symptoms by their malnourished state, right?
So just to share what that looks like in the therapy setting, that study is one that I often will tell patients and families about really early on in treatment, especially for patients who have restrictive eating, or who, in particular, patients who are weight suppressed. And weight suppressed means that the body, all of our bodies have a kind of a happy place in terms of a 10, 15, even 20 pound range where our bodies are pretty comfortable and functioning at their best. And so when someone is restrictive in their eating, they tend to get to the lower end of that range, that sweet spot, so to speak, or under that range. And the moment that the body senses that there's a famine, or that the body's not going to get enough food, there's all sorts of changes that happen in the brain, in the body, hormonally, neurobiologically. And so I tell people a lot about that study because essentially they took these really healthy young army guys who didn't have any hangups about food and were really robust, healthy men with no psychiatric concerns, and under a state of semi-starvation where they were forced to eat much less and to, I think it was over a course of a 3-month period, and the men lost weight. They changed so dramatically, their behaviors changed so dramatically in response to not getting enough food and in response to being underweight. So as you mentioned, they became depressed, anxious, very food focused. They developed funny behaviors around their foods, cutting them up in small pieces, chewing as much gum as they could get a hold of, drinking lots of coffee, getting really distressed if the meal was a little bit late, becoming, some of them even developed kind of almost hoarding behaviors around the food, where they would hoard the food and then they would eat it all at once or eat it very slowly. So essentially they developed these features of anorexia due to starvation, due to not having enough food. And I think it's very validating for people who have struggled with anorexia or similar conditions, because they realize it's not because there's anything wrong with their brains. Actually, it's not that they're crazy at all, that they can't stop thinking about food or planning for food or feeling regret or guilt around food, but it's actually because their brains are starved, that it's changed the way that they're relating to food and to the world emotionally. And that what we see is that as people restore weight and they normalize their eating and they get healthy and nourished again, so we're about halfway through the meal, many of those features restore and normalize, so people can again begin to relate to food a little bit more normally once their bodies are restoring.
Yeah. And I think, the other things to make sure we highlight, we have, trouble with sleep, hopelessness, we can have preoccupation with food. It could be unrelated to food, compulsive and obsessive behavior. I think what's also really important to acknowledge are the cognitive deficits. So we had our colleagues, Drs. Glassifer and Steinglass back in 2011, who put forth a body of evidence that demonstrated there were patients with anorexia who developed visuospatial deficits, poor attention, executive function deficits, other various cognitive disturbances. And in medicine, what we refer to this as is pseudo dementia, right? So pseudo meaning faux, meaning it's not real dementia, because this is reversible. And it's reversible because it's really born from the underlying pathology itself. And the assumption and what we know is that when the underlying issues are treated, that the cognition is restored, unlike dementia, which is a much more permanent unfolding process, right?
Yeah, and that's such a hopeful statement, because a lot can be reversed through becoming more nourished and eating steadily and regularly throughout the day and maintaining a healthy weight. So many of these problems actually end up resolving, which is really hard, I think, for people to understand at the height of illness. I'll see this often with the kids and families that I work with, where we do a form of treatment called family-based treatment, where we're really asking the parents to kind of take control of the feeding for a period of time, so that the child can be nourished and weight restored, at which point they get the control back. And what parents will say is, as they see their child getting nourished, because it's such a containing environment that it really happens steadily over the course of several weeks, as they see their child getting more nourished, they can't but believe how they come back to life. And I'll hear things like, I see my daughter again, she's kind of getting back to her old self. I see her smiling again. I see her engaging. She's less isolated. And even things like eating become easier because the brain is starting to function better. So it's amazing to see how it can really actually be undone.
Yeah. And then, what what we should also look at is on the other side of things, we have the cluster of binge eating disorders, right? What research shows us about bulimia nervosa patients is they have similar characteristics and traits, temperament traits, that is a tendency toward impulsivity, a tendency toward sensation seeking. These are often seen and present early on from childhood. Then we can also appreciate that the patients with bulimia nervosa are having, as we discussed earlier, the signaling differences in their brain reward circuitry, right? So there's already a predilection for certain, if you will, sensory stimuli. And because of this sensory seeking behavior and this attentional bias for it, it's a perfect setup. In the folks with binge eating disorder, what we have really the consensus is that this is a disorder that we can conceptualize as an impulse control disorder, one in which we have altered reward sensitivity, and we have food-related attentional biases. And so what we've seen in some of the brain imaging studies is that there is alterations in the cortical striatal tract. And so this is like the cortex into the area in which we are involved in the reward circuitry, and where we are talking about volitional, making choices, motivation, reward. We also see that there's issues with the neurotransmitter networks involved with dopamine in these folks, as well as the opioid transmitter networks. And so we think that the maladaptive behaviors in BED are all related to this trouble with this circuitry that is challenging the ability to regulate impulse control and motivation. And so we do, in summary, we do see across all of these diagnostic sets, we do see that there's a biological behavior, a neuroanatomical, even if we don't know everything exactly, a neuroanatomical underpinning into the physiology. And understanding this helps us understand how we are going to pharmacologically intervene, right? And what medications are appropriate in terms of helping these patients.
And how much do you find that medication is helpful in eating disorder treatment? And I know that's a very broad question, but yeah, what's been your experience?
You know, it's not fair for me to answer that, because I would say there's a bias. Once people are referred to me, more often than not, it's either the patient or the clinician that they're working with have already gotten to the point where it seems like medication is really needed, you know?
Yeah.
So I would say from my perspective, really helpful, right? Mm-hmm. But again, I look at the literature and I really stand, and the literature helps us stand on the shoulder of giants, which is why we use evidence-based medicine, because these folks have treated conditions and patients in similar situations, so that we can extrapolate and base it on what we are doing, right, and make those choices appropriate. But what I would say is, again, anorexia, what we've got in our arsenal is basically, in terms of affecting outcome, olanzapine, which is Zyprexa, a second generation antipsychotic. What we saw with this drug, so this is also a mood, FDA approved also as a mood stabilizer. What we saw with this drug is we can actually see anorectic patients gain weight, and we can actually see them have less obsessionality around food.
So it does something to target
when
the thoughts. Yeah.
what you said.
Oh, sorry. I think we had a little bit of a hiccup in the technology. I just noted that the olanzapine seems to do something to target the thoughts, and it kind of, I guess, it loosens some of the eating disorder thoughts enough to allow the individual to start eating again.
Yeah, totally. Yep. It is important to note that studies show that it's appropriate choice for adults, but we don't see it changing outcomes in the adolescent population.
Interesting.
And then with regard to the ARFID patient population, there isn't a strong body of evidence. This is a very heterogeneous group of patients, and so it makes it challenging to study and then draw, broad-based conclusions to apply to clinicians and patients alike. But I've seen lots of I've seen lots of case study reports around fluoxetine, olanzapine, and some anecdotal evidence around mirtazapine. Moving on to the more
5 minutes left of the meal portion, just 5 minutes left of the eating.
Oh, sure.
Yep.
Yeah, sure. Would it be helpful to talk about the meds involved in bulimia nervosa and binge eating disorder? Yeah. So in bulimia nervosa, really, we view medication as really being adjunctive. Because the body of literature, I think the most important study was done by Hayes in 2001, suggested that psychotherapy and medication in combination fared better than psychotherapy alone, and psychotherapy alone fared better than medication alone. And the treatment of choice there for bulimia nervosa, that is, it's really the SSRIs because of their safety and tolerability. And specifically, we have fluoxetine, which is Prozac, which has FDA approval for this diagnosis. And it's specifically at dosages of 60 milligrams or above, where we really see a significant curbing in terms of reduction of binging, purging, obsessionality around shape and weight. There are other antidepressants that work, but there's just less evidence to support them. It's important to note that the antidepressant Wellbutrin, which is bupropion, is contraindicated, and that's because there's a seizure risk for this patient population. The medication Topamax, trade name topiramate, which is an anticonvulsant medication. So this is not an antidepressant. This is a GABAergic medication, so a GABA receptor agonist and a glutamate receptor antagonist. GABA is a inhibitory neurotransmitter, and glutamate is a more excitatory neurotransmitter. And this medication has also shown to alleviate symptoms in terms of impulse control and appetite and such. So this is also a treatment of choice. And then I always get the question, well, how long do we keep patients on meds? And because eating disorder populations are so hard to follow in the long term, I can't answer this from an evidence-based point of view. We rely instead, because dropout rates in these studies are so high, so we rely on just the guidelines for depression, anxiety, which basically say 6 to 12 months. And then finally, we have binge eating disorder. For binge eating disorder, we have an FDA approval of a stimulant called Vyvanse, which is lisdexamfetamine, which is an amphetamine prodrug. And this got FDA approval in 2015. We also have antidepressants that can be used. They're shown to be helpful in the short term in curbing binge eating. None were shown to show to be superior in terms of efficacy over the other. So no standouts there. The just final note, I don't know if I have a minute or two to talk about pharmacogenetic testing. One other strategy that we have these days to help guide us in choices are these new tests that are out there. We broadly call them pharmacogenetic tests. Basically, what are they? They are tests where we take a little swab in the buccal cavity. We get some cheek cells. We extract the DNA from these cheek cells. From there, we're able to spit out a report, and then this report allows us to analyze the potential that all these psychotropic drugs has in terms of efficacy for a patient, in terms of tolerability for a patient. We can even assess whether a patient has a normal enzymatic breakdown for folate, which can be really important in assessing whether that patient needs supplementation. So this is really not indicated unless a person has failed at least one medication in the past. But it is a great tool to have at our disposal because it allows us to pick with a little bit more knowledge.
So interesting.
Yeah.
People can ask their doctors about the buccal swab. Is that what it's called? The buccal swab?
Yes. Yeah.
That's interesting.
The two brand names that I know are GeneSight and Genomind.
Okay. I'm just so amazed by your knowledge. You're just like an encyclopedia. And it's so interesting to hear that perspective because it makes the concrete something that doesn't always feel so concrete and helps us remember that that having an eating disorder is not a choice. It's so related to just how your brain is operating at any given time, and very much related to genetics. You know, when we think about why do people get eating disorders, it's very much heritable. You know, that most people who have eating disorders have some sort of genetic vulnerability to having an eating disorder, and it doesn't even mean that a direct parent or sibling has an eating disorder. It can be transgenerational. And not every person that has the genetic loading for an eating disorder ends up with an eating disorder. So there are many factors that go into the development of an eating disorder, but typically there is some kind of a biological component. These are biologically based conditions, as are most mental health conditions. So
yeah, absolutely.
Super helpful to know. So thank you, Nikki.
Oh yeah, my pleasure. Thank you.
I hope that you're able to enjoy your lunch now.
I am beginning.
My lunch. And I'm usually a pretty quick eater and I usually finish before the timer, but for whatever reason, this meal had a lot of bites. It was just a lot of bites. It just kept going on and on with more bites. So I actually just finished within a half an hour. And I feel so often after we complete a meal in a therapeutic meal, we check in on how we're feeling, both physically and emotionally. So physically, I feel very comfortable. I don't feel that I overate. I just felt like kind of just the right amount, and I enjoyed the lunch. It tasted good to me. It felt good to me. And so we usually check in just how we feel. Oftentimes after a meal, people will express feeling full. And that is often very real, because when people struggle with disordered eating, it can change your GI system in such a way. So if you have long periods of restricted eating or irregular eating, it can impact the way that you're actually digesting your food. So what can happen is that as you're eating, the food kind of sits in your stomach a little bit longer. It doesn't empty as quickly. And so that's why many people who struggle with eating disorders will feel excessively full at the end of the meal, or bloated, or just uncomfortable, or even it can feel even painful. And generally, the way that we handle that is we just try to use skills in order to manage the feelings that are coming up, but we do it anyway. We really find that consistent eating and regular eating normalizes the whole system, and digestion begins to move more efficiently, and people tend to have fewer of those stomach aches and bloating and discomfort. And then some people finish the meal and will note that they still feel hungry. And when that happens in a therapeutic meal, we almost always encourage the individual to have more food. In some cases, depending on what the individual person is working on, in some cases, for people who may have more difficulty knowing when to stop eating, sometimes what we'll do is advise that at the end of the meal, they just kind of set a timer, or just, look at the clock and just try to wait a few minutes and see how they feel after a few minutes. And usually what we advise is moving on from the meal with some kind of an activity that doesn't work well with eating. So some kind of activity that takes your attention or takes your hands away, and is not conducive to eating, so that you can kind of have a break from eating and then see how you feel 5 or 10 minutes later. And if you still feel hungry, or you still really want food, then we might advise that you sit back down again, you have some more food, and then you try the same thing again, getting up, taking a break. So after we check in around how we're feeling physically, we check in about how we're feeling emotionally. So to think about, where are you emotionally today? What's your anxiety level? Right now is a time of so much stress and anxiety for everybody. So I would imagine most of you out there are feeling a heightened sense of anxiety. And so what we also do is we think about how we're feeling, and then we go into a coping plan. How are we going to cope with whatever it is that's coming up for us? And when we do a coping plan, we do a few things. Number one is we come up with a very specific plan for what we're going to do after the meal. So that really helps us to move on to something else. It's kind of hard to move on from a meal if you don't have anything to move on to. So we come up with a plan of exactly what the individual is going to do over the next few hours. So it might be, I have got some work to do that I'm going to get to, or I'm going to connect with a friend, or I'm going to take a walk, or I'm going to engage in something that is relaxing and enjoyable to me. Like, I don't know, if you do knitting or drawing or some other kind of pleasurable activity, that can be really helpful after mealtime. And then what we might also even do is kind of cope ahead and almost imagine ourselves engaging in that activity. So really picturing yourself moving from the dining room into, or wherever it is that you're eating, your desk, to another space, and what it's going to look like as you re-engage in another activity. And we also cope ahead around any skills that we need to use. So the skills that we talk about are simple skills for self-soothing, things like breathing deeply, settling yourself, doing some kind of progressive relaxation, some kind of meditative exercise. It might be a distraction exercise. It might be some kind of self-care activity that is stabilizing and soothing. It could be lighting some candles, or using some scented hand lotion, or wrapping up in a cozy blanket and getting a book, something that feels nurturing. So we cope ahead both in terms of what are the activities we're going to engage, and what are some of the ways that we're going to take over the mind, so that we can keep our minds from reflecting and worrying and perseverating on what we've just eaten. So I'm going to actually teach a new skill today, and I picked it because it's a little bit more mechanical and sciencey, if you will, in light of the fact that we had a doctor here today and we were talking about the brain. And this is one of our favorite skills to use when you're really not feeling well, when you're really feeling very distressed. So when we think about our emotional state, we can think about it moving from a 1 to a 10. And let's say when we're a 1, we're totally relaxed, we're content, we're feeling secure and safe, and not feeling at all activated. And when we're a 10, we're hot, we're in our heads, we're emotional, we are not really able to access order or thought or really kind of think through the consequences of any of the actions that we are engaging in. So when we're at a 7 to a 10, we might be much more impulsive. We might be kind of moving from the hip, like moving in response to emotion. And so we're talking about a skill right now to use when you're a 7 to a 10, when you're feeling really, really angry or really, really anxious. And we call this one the ice trick. And the ice trick is a way of actually shocking your body for a moment into activating your parasympathetic nervous system. So the parasympathetic nervous system is the system in your body that helps to relax you and slow you down. It actually is the system that also helps you to digest. So when we're feeling really, really activated, we want to decrease our arousal so that we can be engage in a way that we're going to feel good about, that we're not going to do anything really impulsive or anything that we're going to regret. So we use this particular ice trick. And what science shows, actually what research shows, is that even if you splash your face with cold water, really cold water, just doing that and holding your breath for a second, maybe like 10 seconds, just doing that actually can reduce your heart rate from 10 to 25%. And then we kind of take it even one step further in that we sometimes advise our patients to grab some ice or get really cold water with some ice cubes in it, or get a bag of peas. And when we take that really icy cold water and we splash it on our faces, or we kind of dunk our faces in for a second, or even just the cold peas, you hold it against your neck and it kind of shocks your system and it activates this mammalian dive reflex, which apparently, I guess since life forms evolved from the ocean, it's this really old adaptation in our bodies that helps us to dive into water. So when you splash the really icy cold water on your face, you're actually shocking your body so that your heart rate immediately starts to lower. And actually there's some constriction of some blood vessels. So the blood actually moves from your extremities more into your vital organs, including your heart and your brain. And we really want the blood flow to our brains when we feel completely overwhelmed with emotion. And so the idea is that you notice that you're starting to get there. You've moved from a 6 to a 7, maybe you're moving up to an 8 or a 9 or a 10, and you're just starting to feel a little bit of a loss of control over yourself, your emotions, and you just find some ice somehow, icy cold water, peas, ice cubes. Some people keep things in their freezer specifically for this purpose. And you splash your face or you hold it against your body. And at the same time, there are 2 other things that you can do. So that could help a ton. It's kind of our go-to skill. The other thing that you can do is to first focus in on your breathing. And the trick to breathing when you're really at a 10 is that you breathe out for longer than you breathe in. So let's say you take a breath in for about 5 seconds. You make sure that as you breathe out, it's a little bit longer. It's about 7 seconds for breathing out. And what we usually advise is that you're actually counting as you do it. So you count 2, 3, 4, 5 as you breathe in. Maybe hold it for just a second and then breathe out for the 7 seconds. This also tricks your body into calming down. What you can also do is something called progressive muscle relaxation paired with breathing. So you pair your inhalation of air with tensing your muscles. And when you exhale the air, you release your muscles. And this serves a similar function to the breathing and to the ice water in that it triggers the parasympathetic nervous system. So, and what we really like to do with this is practice doing it discreetly. So oftentimes during meal supports at the center, we might not even realize, but people at the table may be practicing progressive muscle relaxation along with paced breathing. So you could breathe in, and as you breathe in, like clench your fists really hard, or clench your feet on the floor, or really push them deeply into the floor, kind of activating the backs of your legs. Or you can try to squeeze your butt muscles together really hard. And as you do that, you're going to inhale as you squeeze. And then as you exhale, you begin to let go of the tension and exhale just a little bit longer than the inhale. So inhaling and breathing in for about 5 seconds, and then exhaling and letting the muscles go for about 7 seconds. And what we find is that this can do, it's not that it makes everything go away and that that it, relieves you of whatever it is, whatever problem it is that you're having and the emotion that you're experiencing, but it actually helps you to get a little bit more emotional control and in control of the actions and the behaviors that you're going to engage in as you're working through whatever emotion is coming. So I'm going to remind myself to use this temperature skill. It's called the ice trick, paced breathing, and progressive relaxation. And the next time I'm furious at my children and I notice that I'm losing control, I'm going to try practicing maybe the ice or maybe just the breathing in and holding my fists and letting my fists go so I can kind of settle myself down a little bit. At any rate, Nikki, it was so great to have you today.
Oh, thank you. Thank you. It was wonderful.
I hope that everybody comes back. If you go to the My 3 Square website, so it's the number 3 and the word square.com, you'll see our free live meal support, the calendar there, and you'll be able to see our upcoming guests, the dates, the times of our programming. And I hope everybody has a distress-free day, and don't forget to breathe. Thank you very much.
Thank you.